Hello friends, trochanteric fractures can often be challenging, and the situations when you have a distal femur fracture which has been recently fixed makes the procedure more challenging because you don't have the option of implant removal and placement of a nail for the trochanteric fracture. And if you remove the implant, you may create a stress riser that can actually result in a fracture at the junction of the nail and the previous fracture site. So I will be discussing a case today in which the patient had a comminuted distal femur fracture which was around 3 months old and was fixed with the distal femur locking plate using MIPO technique, and the fracture of the proximal femur was there in the trochanteric area and it was comminuted, was deforming in varus, and you can see there are separate fragments of the greater trochanter. There is comminution on the lateral wall and there is a separate fragment of the lesser trochanter. So kind of comminuted fracture that we often see in a geriatric patient. So we'll be seeing what kind of treatment option we have in such an injury through a case example. So this was the initial injury of the patient. You see there is comminuted intra-articular fracture of distal femur that was fixed with MIPO technique. The fracture reduction was obtained indirectly by palpating the trochlear area and the alignment appears to be satisfactory. We have screw density of less than 50% in the diaphyseal zone, and the terminal screw is a unicortical one just to avoid stress riser since the patient is an old one, a geriatric patient that is more than 60 years of age. And these stapler marks, you can see they are the incision marks which show that the procedure was done in a minimally invasive manner. And this was the articular reduction intraoperatively, and you see in postoperative CT the reduction is perfect. The articular part of the trochlea has been perfectly reduced. Ultimately the outcome should be satisfactory, and after 1.5 months we started seeing some amount of callus formation. Some may argue that we should have supplemented this fixation with a medial plate as well, but the problem is that this patient was a multiply injured patient and we do not want to proceed with a long surgery in these patients, and we tend to do medial plating if there are signs of delayed union. That means we don't see any progression of the callus formation here on the medial side. In the lateral approach we don't touch this part at all and it has to heal because the vascularity is not disturbed. And these locking plates, the lateral side locking plates, are rigid enough to provide the adequate stability when there is medial comminution, especially when fixed in a proper manner. That means you have gained good hold in the periarticular part and the screw density in the upper part is 50% and you don't place any screw in the comminuted zone. So by that principle we should be able to achieve good healing. So the same thing was happening. You see the callus formation is there in the lateral view as well, and this was the radiograph after 3 months. You see good amount of callus formation is there, more than the previous x-ray in both AP as well as lateral view. But unfortunately the patient became over enthusiastic and stopped using the walker support and had a fall again and sustained this injury. You see there is trochanteric fracture, a comminuted one, but you see the fracture didn't happen in this zone because the stress risers were avoided in the previous surgery. Otherwise, if we would have crowded screw density here, then probably a subtrochanteric fracture would have resulted. So now what we have in the treatment option? So we can't place a nail through this zone because we'll have to remove this screw, and ultimately the stability of this plate will get compromised if we place a long nail which is ending here. And also it will be difficult to pass the nail through this comminuted zone because this part will be sclerotic. There are multiple cortical fragments lying inside the canal, so you are going to face difficulty if you are planning for the nail. You will not be able to create a track like this and you will need to remove all these screws. Since it is only 3 months after the injury, while we have the good callus formation, it is not consolidated. That means removal of the implant can actually result in a stress fracture in this zone because the bone is still weak. So we want something in which we have to retain this implant with good number of screws in the proximal part as well, while retaining these screw as well. And also we don't have the option of DFN since the fracture is in trochanteric region. We have to use the antegrade nail only, that means the proximal femur nail or a trochanteric femur nail which is used in proximal femur fractures. A long nail is placed and ultimately the terminal screws or bolts of the nail are going to end somewhere here. You are not going to get hold in this zone because the nail end will not go beyond this point. This point is the highest part of the intercondylar notch, or you can say the Blumenset line terminal part. So your screws of the nail will be coming somewhere here. You might think that you can place some screws here and you will face difficulty in localizing them because the nail will block the view of those screw holes. So you see, if we see the lateral view, the screw or bolt of the nail will be coming somewhere here. So a short nail is definitely a good option, and in short nail we'll have to try for the longest form of the short nail. That means around 235 or 240 millimeter will be a good nail. So probably the nails ending somewhere here is a good option. By that we'll be able to retain these two locking screws, because we are still waiting for the consolidation of this part, and the stability of the two locking screws here will be supplemented by the new bone formation that is happening here. But keeping the plate only with one screw is not a good option, because ultimately that screw will be the sole screw that will be absorbing whole of the stress in this part. So retaining two screws is probably a better option. Now comes the another issue. You see the thickness of the thigh. The trochanteric part is almost 12 cm away from the thigh lateral aspect. So this patient was an obese elderly patient, and you see this fragment is going in varus. So ultimately you have to ensure a medial entry, and if you are not going to get a medial entry, there are chances of wedge effect and you'll get a varus reduction, and the proximal screw will end somewhere in the superior quadrant. So you have to take care of that also. So this was the reduction we got on fracture table. While AP view appears to be satisfactory, the lateral view is not good. So you see the proximal fragment is translating anteriorly. So again, a difficult scenario in an obese patient. So the proximal fragment was controlled by placement of an anterior homen, and that reduced it in lateral view as well. But in AP view, what happened? This, you see that shaft part has translated laterally. But again, we can do some maneuver to push it more medially. And you see, now we are realizing it is more of a subtrochanteric fracture. The fracture is somewhere here. So again, entry point that is on medial side is the option that we need. Now the patient was an obese one, and it was difficult to gain an entry through a guide wire that is going medial to the tip of trochanter. So ultimately we used a long curved awl to just make a small hole here in the part which is medial to the trochanteric tip. We have to eat up this bone, otherwise what will happen? There will be wedge effect. So even if your entry is merging with the trochanter, but you have removed this medial bone, then your outcome will be good. That I'll show you in the coming images. So we place the awl here just to ensure that this awl breaks this medial bone so that the wedge effect is prevented. So you see in this image, this medial bone has been removed, even though the awl is going laterally, because you see the trochanter part was comminuted. Ultimately this whole entry part is going to merge because of the comminution. And with the help of awl, we were able to push a long guide wire inside the canal. A push was given from the lateral side here to push the shaft more medially so that a guide wire can be inserted inside the canal. You see something like this was done. And don't care about the awl going laterally now, because you have removed this bone. Ultimately when compression happens, the bone here will ultimately come in contact with the nail. Even if it is not happening intraoperatively, it will happen during the follow-up. So we had selected the longest form of the short nail, that was 240 millimeter. But you see we have removed two screws, one here, and the terminal part of the nail is actually hitting the screw. So this nail is not the right option. So we changed the nail and used a nail which is 200 millimeter in length. So the nail length was now ending proximal to the third screw here, and we were able to retain two locking screws inside the plate. And you see, while the fracture is slightly distracted, that should not be an issue, as I'll show you in the coming image. And our guide wire is going in a good position. It is going inferior. And this is the ultimate length of the nail that we are getting. It is good enough to span the zone which has been occupied by the plate. So we are ensuring that two implants are merging with each other. Now you have to be careful in this step. You have to ensure that you'll be able to assess the distal locking hole through any of the screw holes of the plate, because you will not be having any other space for placement of the screw or bolt inside the nail if we end up this hole somewhere in this area in which we don't have any hole for screw placement. Right now, if we are in a situation, we can't push the nail further, and if we try to remove the nail slightly, we'll end up putting the screw in the superior quadrant that we don't want to happen. So ultimately this position was selected in which we have some access to this hole through the hole of the plate here. And also you have to ensure that the guide wire is going in a correct position or a biomechanically superior position, that means the inferior and posterior quadrant. So the blade was inserted. Now you see there's some distraction at the fracture site here, and I told you it won't be an issue because if you see the direction of the blade, it is like this, and the same will be the direction of the compression of the fracture site. So ultimately this fragment will come somewhere here if we draw a parallel line. So this is actually the positive reduction. We'll try it for intraoperative compression, but if it is not happening, that won't be an issue, and the direction of collapse will be parallel to the leg screw direction or the blade direction, because in this is osteoporotic patient, we have placed a blade inside the proximal femur. Then we tried for obtaining the compression, but you see the part of bone here is already impacted and we were not able to gain compression. This fragment of GT actually displaced, but that won't be an issue because overall alignment of the fracture is in good position. It is valgus and the blade is in good position. In lateral view also, the blade was in a good position. It was almost centrally located. So if we are erring, we have to err towards the posterior side, but if it's central, then also it is good. But definitely do not go in this part, superior quadrant, because that is the area of weak bone. So now comes the distal locking part. So for distal locking, you will not be able to see anything in the lateral view because the nail and the plate will be coming in same plane, and you'll be able to see the distal locking hole only if the X-ray beam is passing perfectly along the two holes. That means the distal locking hole here and any hole of the plate. But it is very difficult to get such a view with the C-arm in fracture table. So we created a hole using the drill bit on the lateral side through a hole of the plate which was closest to the distal locking hole of the nail, and then we used a smaller drill bit just to feel where the hole of the nail lies. So ultimately we were able to create a hole like this here. Once the hole was located, we checked a lateral view. In lateral view, we ensured that the drill bit that we have inserted is not going anywhere anterior to the nail somewhere here or posterior to the nail. Ultimately we are over the nail or inside the nail in this zone. So ultimately we drilled the track like this so that we were able to span the whole of the plate as well as of the nail. So by that we'll be able to put the screw in this direction. So now we have created a track with a smaller drill bit. We use the conventional drill bit and it was easy to place that drill bit because we have already created a smaller track through this hole. Then we place the screw, and you see it was going through the holes of both the plate as well as of the nail. So this track was created. So this part is the tricky part. You have to ensure that you'll be able to pass a screw through this zone. So you have to ensure the correct position of the dislocking screw hole of the nail as well as the proximal part of the nail in a correct position. That means your screw or blade should be in the good quadrant, that means inferior quadrant. Do not compromise with the fixation in this part because ultimately that will guide the outcome of the patient. So minor adjustment can be done in this part, but you have to ensure that proximal part has been well positioned. So this was the post-operative radiograph of this patient. While we were trying to gain compression intraoperatively, that was not happening because the hold of the bone here was not good. In the attempt of getting compression, the blade was actually sliding slightly outwards. So that was not the thing that we want. We wanted intraoperative compression, and because of the poor hold, that was not happening. But we are still satisfied because ultimately I've told you that the direction of compression will be like this because that is parallel to the blade, and this fragment will come somewhere here in the follow-up. And since we have removed the bone here, that will not prevent the collapse. You have to ensure that the medial bone has been removed and the position of the trochanteric fragment is not an issue at all. It can come somewhere here, it can come proximal, it can come outwards also, but that won't be an issue because that is the comminuted fragment and it can go anywhere. But since this is a low energy fracture, it is not an avulsion injury. That means the continuity of the muscles, the gluteus medius and the vastus muscles is still maintained. These fragments will not avulse and migrate proximally, unlike in a high energy trauma. So definitely we are anticipating a good collapse happening here. And also when we are anticipating collapse, you have to ensure the correct length of the blade. If we keep the blade protruded like this somewhere here, ultimately the blade will come somewhere here after the collapse. So you have to ensure that the blade is perfectly inserted inside the bone. That means almost flush with the bone when selecting the correct length of the blade. So we have a common zone that is occupied by the nail and the plate, and the nail has now been linked with the plate. The linking is something which is actually contributing to the stability of the two constructs. So the nail is now part of the plate and plate is now part of the nail because this screw is actually connecting these two implants, and whenever you have linked two implants, that is going to add more stability. So this was the ultimate follow-up of this patient. You see the varus collapse didn't happen and the posterior cortex that was maintained here is still there. I told you this fragment will end up somewhere here because the direction of compression is like this, and ultimately that thing happened. The proximal spike is not going inside the canal, And also I told you that since we have removed this bone, ultimately the nail is going to come in contact with the medial bone here, and same thing happened. And also I told you that trochanteric fragment will not hinder your reduction because it is already completed. So even if it is lying here, here or here, it will not hinder the compression or collapse that will happen in the follow-up. And one more thing, you have to ensure that the set screw is not fully tightened. You should allow some amount of gliding if the fracture site is slightly distracted. So this distraction can remain when the hold of blade is not good. That means when you try to gain compression, in spite of this fragment coming towards the nail, actually the blade comes slightly outwards. So in that scenario, you better keep the fracture site distracted and keep the set screw slightly loose so that you have compression in the follow-up. And same thing happened here, and the fracture healed satisfactorily. And you see there is some consolidation happening at the distal fracture site also. So ultimately the patient outcome was satisfactory. Patient was happy. He was well mobilized. He had almost full range of motion at the knee joint, and the hip part was also asymptomatic. And this was the follow-up radiograph at 3 months, and the patient was mobilized with the help of a cane and full weight bearing. So this was just a case example to show you how you can tackle similar injury. You can have other options also, but this can be definitely a good option in which you have linked a short nail with the pre-existing distal femur locking plate. Ultimately, the outcome will be satisfactory. If you have any case, you can just put those in comments. Thank you.